PBC in 2020, and I'm going to touch on a little bit of what practice is like and where we are, a little bit of COVID, something that's important and topical, and a little bit of the research data that I know people find very interesting, and then a little bit of a sense of where we're going with it, because we are, I think, at one of those times, one of those very interesting times where we're taking a big and rapid leap forward. So this often happens in conditions where it can be quiet for a long time, and then there's a big leap forward, and then it's quiet for a time, and then you have a big leap forward. And I think, for example, liver cancer is going to be one of those areas with enormously rapid advances. So I think, so we are at a very exciting time, and I'll just give you a flavour of where we're up to with it. So PBC in 2020. So we're asked about this all the time, and I think it's just very useful to talk about COVID. Where are we with PBC? What is the consensus and what is the guidance that we're giving? And I think you have to recognise that there is sort of official safety first guidance sometimes, but there is also, if you like, our opinion and our experience from the front line, and also talking to colleagues in Milan, Paris and places that had a lot of problems with PBC. So what is the bottom line with PBC and COVID? The first thing is, for non-cirrhotic PBC patients, there appears to be no additional risk, either to their disease, in terms of their disease getting worse, or for them getting COVID. So we are seeing very little signal indeed. In fact, we probably see fewer cases as statistically we ought to. So new people are concerned correctly, and safety first was obviously the right thing to do, but we are not seeing a signal. For cirrhotic patients, it's a small minority of people with PBC, there are additional risks. And deaths are reported, although not amongst our population. So, so that does seem to be something to be aware of. I think we are hearing all the time concern about breakdown in normal care. I'd like to think that here we've done it very well. And Jess, who is known to all of you, I think, has done a just phenomenal job converting the clinic to an online version and then back to a mixed version. So I pay absolute tribute to her hard work with that. And I think we've learned something interesting, actually, that there are times when phone catch-ups are convenient and useful for people. They should never be, I think, the exclusive way of doing it. But undoubtedly, we have people coming from a long distance who catching up 2 or 3 times a year on the phone and then coming up for a once-a-year visit will actually work very well for them. So I think we're going to offer a blended model in the future. But the idea will be, it's very much up to individuals how they want to do it. I think we would still always want to see people once a year and see people for the first time. So we are working on all of that. Again, not around here, but there are issues about asymmetry of care. By that, I mean, we've offered as good a service as we possibly can in the circumstances. So we are still managing people effectively, but that is not the case across the country. And there are examples of people essentially being discharged from care with PBC, and we need to work on that for the future. So I think there is a danger that the centres that offer a good deal to people normally, that they've continued to do that. So we've kind of worsened care gaps. And it emphasises what we already know, that basically in PBC, you want to avoid cirrhosis. If you avoid cirrhosis, then that's sort of 9/10 of the battle. So avoid cirrhosis, that's key. And we need to have some more resilient approaches to optimal care delivery. We need to have a system to deliver care that doesn't break down if people can't come through to the clinic. So I think those are 2 conclusions. So we've been doing a lot of thinking about this, and this seems, in a sense obvious, but actually to a lot of clinicians it isn't. So what are we trying to do? We're trying to do 4 things. We're trying to give people as close to a normal length of life as is possible. So we want people to live a normal length of life. Absolutely fundamentally important that life is as high quality as is possible. So don't extend life at the risk of quality of life. We want to use the lowest invasive and lowest dose treatment possible. So we want to use just the right level of treatment in terms of side effects, and people want to be involved in decisions and treated with respect. And that's our manifesto moving forward for what we're setting out to do. Length of life, quality of life, optimized treatment, the mummy bear regime, neither too hot nor too cold, and always treat people with respect and always involve them in their decisions. And we are increasingly in a world where there are decisions to be made about the treatments that you give. And when I'm training people, I keep coming back to this all the time, all the time. Simple things done well every time is the answer, okay? Simple things done well every time. One of the other mantras, very interesting, that we use all the time is three things for people. The first is don't panic with management of people. You've got time to think it through. Second thing is simple things done well every time. The third is don't change what you do until you've given the first thing chance to work. And I wonder if those are useful words for people managing COVID nationally, but I won't comment further on that. So what do we think makes a real difference in terms of management? So effective treatment in early disease to stop progression. I'm not going to show my Eric Morecambe slide, but Eric Morecambe's great. I'm playing all the right notes, just not in the right order. I think that is increasingly the punchline of this talk, is that we are now at a point, we've got fabulous treatments in PBC. The next revolution is how we use them, when we use them, and who we use them. The mantra to go with the others that we're using is better treatment given earlier. So we are waiting and delaying with treatment. So effective treatment in early disease to stop progression. If cirrhosis has developed, and we do see people who present late, you know, it's one of those things, we can only manage the people we see, then screening for and treating the complications is obviously critical. So in that sense, people with PBC are like patients with all types of liver disease. Timely referral for transplant, but we always remind people that transplant is in a sense a failure to manage the disease. No patient with PBC in 2020 presenting an early disease should ever go on and need a transplant, ever. So in a sense, we're catching up with people who weren't able to be treated in that way. Effective symptom control is an absolute must for that length of life and quality of life. And I think there's a real need around support around key life issues. And I think things that we are not very good at, I am not very good at, around those things that are part of an essential, normal, healthy life. And I'm delighted that Kath Houghton, who a number of people will know, was a research nurse with us. She's now in a half-time specialist nurse role with us, developing that in the clinic. And she is going to be offering support around life with PBC and autoimmune hepatitis and these conditions. So from a nursing perspective, doctors always approach it from ill health and trying to treat that. And the nursing model is to approach from normal health and how to stay that way. And it's an important sort of philosophical difference. How does it go wrong? Late or misdiagnosis, and we're all very familiar with assumptions about alcohol, particularly men with PBC. People assume it's something else, and the stereotypes. Then where people are diagnosed, treatment has not started. There is a drift, 6 months to see if the liver blood tests return on their normal, then just check it for a year and then wait 18 months. And we find that on average, people wait 3 years before they start treatment, which is unnecessary, absolutely unnecessary. We would always start people on therapy the day they come to the clinic, but it's elsewhere, it's a real issue. Under treatment, pointless arguments about the reality of symptoms. I'm bored of this. People saying that fatigue doesn't exist and fatigue isn't real. As you know, and work that stretches back many, many years and funded by LIVErNORTH has now led to exquisitely detailed imaging of people's brains, which is going to lead to some therapy that I'm going to talk about later. There's a clear issue going on. It's organic, it's real. Let's stop arguing about symptoms are really there. And where people are referred for transplant, they are sometimes referred from other centres too late. So it's just worth remembering how this is done. And I think one of the messages we're increasingly giving to patients is take ownership of this. If you're not happy with what's happening, get in touch through LIVErNORTH. The lines of communication are very good. We can intervene without causing difficulty. So coming to see us to participate in research for years has been a way of bringing people through into a clinical service. So don't let you or your relations suffer from wanting to not offend a doctor. I'm very happy to be offended. So this is where we've ended up. So one of the problems with management is you've got to have simple and clear-cut guidelines about what you're doing. So these are the current European guidelines. The UK guidelines are essentially identical. And this is the structure for managing PBC, and you've essentially got 3 pillars: pillar here, and pillar here. And I'll run through what those 3 pillars are, because it gives a structure to what you do. But of course, before you do that, you have to diagnose and treat what you've diagnosed. Obviously, that needs people to think about it. This is my favorite image from Thomas Addison's original book, image of somebody with PBC. And clearly, end-stage disease is a rare but occasional presentation, but most people present either with these symptoms which don't shout PBC, often get missed, or the people whose blood tests are abnormal when they're screened for something. So we are endlessly nagging people that PBC is in fact the commonest reason to have a raised alkaline phosphatase blood test in women over the age of 40. It's the commonest, full stop. So anybody who has a raised blood test like that, people should instantly think about it. And then the antibody testing is very effective and very simple. Now, this is something that's, I think, incredibly interesting. So this is Jess's work, and follows on from something that Oliver James started many, many years ago, which is this really fascinating question: why do we see so much PBC in the northeast of England, and why do we see it concentrated in particular parts of the northeast? And this is Jess's absolutely painstaking, and I think absolutely fascinating work. So what she did is to map everybody with PBC across the northeast and Cumbria. And this is the density of PBC corrected for how many people live there, because clearly if you don't correct for the overall population, it'll be commoner in cities, full stop. So this is adjusted for population. And when you do this, you see some areas with very, very low amounts of PBC, and then you see some areas with very high levels. And you'll have seen me show pictures and Oliver showed pictures in the past which were a bit fuzzy. This is now not fuzzy at all. We are using really high-end computing to be able to narrow down on this. Is that significant? We're being bombarded with information all the time. One of the things we never really talk about is that significant? Is that real? Well, this is a really robust statistical test applied. So of those dark blue areas, the ones in red are statistically significant beyond any question, and the ones in green are for high disease, and the ones in green are low disease beyond any statistical question. So PBC is clustered, and it's here in North Tyneside and just south of the river in North Durham, South Northumberland, and it's very low down here in the Vale of York, interestingly. That's in a sense what Oliver did, but to a higher degree of accuracy. So where it gets really interesting, because what Jess did is then overlay lots and lots of information that we know about the Northeast. So there is an absolutely extraordinary wealth of information that is out there present in the literature and in resources, the British Geological Survey, Public Health England, etc., etc., etc. So they looked at all manner of different environmental distributions of things that we know about in the Northeast and all over the place. And what you see here is this is a map of the Northeast with 2 things plotted on it. Remember, this is high PBC, this is low PBC. And what this is the black dots are coal mines, okay? And the yellow underneath it all is environmental cadmium, which is a heavy metal which is present in post-industrial settings. It gets to be leached out of mine workings and industrial settings. And so what you can see in this area here is a very high concentration of mines and a very high concentration of cadmium. Interestingly, down here, it's a lot of cadmium, but is not any coal mining, okay? So just cadmium on its own doesn't seem to do it. And over here, you have coal mining, but no cadmium. You seem to need to have both. So we think it's the mine disrupts cadmium in the soil, brings it out to the surface, and cadmium gets concentrated in the bile where we think it maybe has its actions. And it's, I think, a truly fascinating question. And she's worked this out. About 50% of the risk of PBC that's not genetic, if you like, comes from living in an area related to coal mining and related to high levels of cadmium in the environment. So this is not the level that we can do anything with it yet in terms of prevention, but I think it's just very interesting. And this is just fascinating work. And I think it's been sort of 20 years in the making with Oliver's work. So we might come back to that in the questions. So where are we up to in therapy? I'll rattle through this very quickly. So the message about ursodeoxycholic acid is you give it to everybody, and you give it at the dose of 13 to 15 milligrams per kilogram per day. No ifs, no buts, no does it work, does it not work, doesn't know giving it. I came across somebody who's done badly with PBC elsewhere through the legal system, who'd not been treated for 10 years because she had no symptoms from a PBC. It's got nothing to do with it. Everybody should get urso. If you can't tolerate it, you can't tolerate it. You need to look at individually about what you then do with this. So the starting point with urso should be universal. The dose thing is very important. We've upped the dose. So in the old days, we used to give people about 900 milligrams a day. It's now much more likely to be 1200 milligrams per day. This is what happens. This is transplant-free survival. These are people who don't have urso. So this is not good for you. These are people who have urso, so urso is good. The light blue line is people who have the right dose, and the dark blue line is people who have too low a dose. So it does make a difference to get the dose right. So what we're doing in the clinic at the moment is just making sure that everybody is taking the right dose. That is important. But we are now seeing pretty much everybody who comes to transplant now is being treated with urso. So urso clearly is only partially effective. And this whole question that's become very, very important in management is about whether you respond to it, whether you don't respond to it. So we give urso to everybody, but we then need to look at people after a year and decide whether their blood tests have basically improved enough with it. And this is the UK data that we published a number of years ago. These are different cutoffs for alkaline phosphatase and bilirubin. And the people in red are the ones who don't reach that level that you want them to get down to. The people in blue are the ones who do, and this is survival again. So clearly, if your blood tests don't improve enough, you do badly with PBC. So the people in blue are the majority. That's great news. They're doing well on this. This is a milder, more responsive disease. But the people in red need more treatment. And that's really the heart of what we now do with PBC. It's an interesting question about what's the right cutoff. So we ended up with this quite complicated alkaline phosphatase 1.67 times the upper limit of normal. So it all gets a bit clunky. We asked all the time in the clinic, you know, what are my blood tests like? What's the answer to that? What are you aiming for? This is some data from the global PBC study group, who in a sense, it's interesting, the global PBC study group have recruited as many people across the world as we have recruited in half the UK, but in the UK PBC, but I pass no comment on that. Anyway, this is their data, which goes back a long time. And basically, this is your risk associated with a rise in alkaline phosphatase. And actually, this is the upper limit of normal. This is the rise. Doesn't really matter how elevated your alkaline phosphatase phase is. It seems like the risk goes up and up and up. And this is some interesting data. So from that, you could argue that actually these arbitrary cutoffs are not what you want. You want to have normal. And there's even goes beyond that into a question of what about a normal bilirubin? Well, actually, there is some evidence that if you have a bilirubin below the upper limit of normal, so actually within the normal range, your bilirubin matters as well. So we are in the process, I think, of tightening up our target. And I think before too long, it's going to be normal. That as with autoimmune hepatitis, as with NASH or whatever, we are looking for normal blood tests as the goal of treatment. And that will be a really important change. You are the only people in the world who have seen this picture. There you go. That's a unique thing. You're the only people who've seen this picture, largely because I drew it this afternoon. And this is some of the data that's coming out from UK PBC. And this is looking at blood markers. And the detail of this doesn't matter, but this is the level of a blood marker associated with immune response. These are those two groups of people who have normal liver blood tests. These are the ones who are ultra normal. These are the ones who are, you know, slightly closer to the upper limit of normal, but still normal. This is the marker in levels of increasing abnormality of the blood tests. So these over here are people who, until about 2 years ago, we would say actually are responders to URSO treatment. That is very significantly different. We would say they're normal and they're doing fine. The disease is still clearly active. These are the people who actually respond to the cutoff we use in the clinic at the moment, still elevated. These are people with any elevation of their liver blood test, tiny elevations, still higher. So we now, I think, have both clinical evidence and mechanism evidence to suggest that only normal is normal. And I think that's a mantra you will increasingly hear. So we are going to be tightening up our target. And people will sometimes say, well, hang on, you're telling me I'm not doing well enough in my treatment, but last year I was doing fine. Well, that's a bit like cholesterol. Everyone's familiar with the targets for cholesterol progressively, got lower and lower. So somebody who was okay last year is not okay this year, even though their cholesterol number is the same, because we're looking for a higher level of control. So watch this space. And I personally think we should be aiming for normal blood tests. This, without getting too technical, this looks at proteins in people with PBC, and the important message is this blue blob. There is one protein which returns to normal in people when they're treated with URSO, one, okay? And this is really the starting point for what I've showed you, which is that the danger with URSO on its own is it's not enough to normalize people. Some people, yes, but only if you get normal blood tests. So it's part of tightening the target up. So URSO for everybody, but, and it's a big but, it only works up to a point. And so we now need to look at whether people have responded. As I said, we look at normal bilirubin and 1.67 times epilimumab of alpha is about 200. Alkaline phosphatase is about 200. Increasingly, we're going to be going for normal as the target. And if you don't reach that target, then we now add a second treatment in. So that's a big change in PBC. This is trial work that many people in Newcastle participated in. It was led and initiated out of here, and it's now, in worldwide clinical practice. So now, if you don't respond enough to URSO, it's a higher level at the moment. We're going to tighten that. It's a second treatment. And this is where drugs like obeticholic acid and bezafibrate come in. Very important that this is not an age equal thing. The younger you are with your PBC, when you present, the more likely you are to not respond to therapy. So when people do present over the age of 70, it's usually a much milder disease in terms of severity. It can still be symptomatic, but as long as people haven't had the disease for a long period of time and just presenting late in the disease course, tends to be milder, but the younger patients are much more likely to need a second treatment. And so if you look in our treatment clinics, it's very clear that effect is there. And if you look at people who've had a liver transplant with PBC, they often presented below the age of 50. So two big trials of drugs, these are the ones we use in practice, obeticholic acid, and then one of bezafibrate. And this is an indication of how much the world has moved on, that we now have alternative second-line therapies. There are options for treatment, and I love having options for treatment. It allows us to use the right treatment in the right person. So I'll just run through these a little bit. I think they're quite important trials. So these are the people in the obeticholic acid. This is the Intercept drug, Ocaliva. Doesn't really matter this data, but just to show you this one thing, age at diagnosis, average age was 47, 48, 47 in the different groups. People present below the age of 50, just to make that point. And these had to be non-responders to URSO to come into this. Basically, it was about normalizing blood tests within that range. So did you reach that 1.67 times epilimumab normal plus normal bilirubin? And the answer is about 50% of people treated with obeticholic acid at 12 months have reached our treatment target. So these are people who haven't reached that target with URSO alone, do nothing other than give them placebo, about 10% respond, and about 50% will reach that target, which means about 50% don't. So we're chipping away at the treatment need, although we're going to make things more difficult for ourselves by having a tighter therapy target, I think. The blood tests improve very quickly. This is alkaline phosphatase. The one to look for is the blue. That's the dosing regime we use in practice. Really quickly decreased then by 3 months, it's pretty much reached the long-term thing. And we followed people up in this trial for 2 years, and it stays improved by 2 years. And a whole raft of other different sort of markers of the disease also improves. So there is a generalized improvement in the disease activity, which is important. It can, however, cause itch, and this is one of the issues with obeticholic acid. That blue squares, again, are what you need to look at. What you can see is that there is an onset of itch in some people, although it does wear off. So by 12 months, people are indistinguishable in terms of whether they took the drug or placebo. The itch has settled down, but it can cause itch at the very beginning. We now have mitigation strategies in place for people who do get the itch, and those can be quite effective. So we need to be aware of this and warn people. We've now followed people up for 48 months, and the answer is absolutely nothing happens to them. So basically that improvement you see at the beginning, it goes down a little bit after 3 months, then flattens out and basically stays like that forever. But what this does mean is we've now got many thousands of patient years of use of obeticholic acid. So we have treated people for a long period of time. So, and that's very useful in terms of reassurance about safety. Bezafibrate is the competing drug, same thing. If you look at the age at presentation, again, 46 to 49. So again, young people. But one of the important things to just say is that this was a milder severity group of people to the obeticholic acid trial. And that is important as we move forward. These people were a little bit easier to treat. They used a lower cutoff for alkaline phosphatase to come into it. And that's the point here. So the upper limit of normal in our clinic is 130. We were looking originally to get people under 200. We're now looking for under 130, so we've made life difficult for ourselves, but we're seeking perfection. But in this study, people had an average of about 240, so that's 110 points above the upper limit of normal. In boys, it was 330, so that was nearly 200 points, nearly twice as elevated. So these are a more difficult to treat population. If you take people with PBC in the UK who've had obeticholic acid on the NHS, they've got an even more aggressive disease. So this is a drug used in a milder population. I've taken out the results slide. How silly of me. Right. What that showed is around about the same effect as obeticholic acid. So you saw around a 50% response to therapy, but they started to see normalization as well. So they saw about 20% of people going all the way down to normal, which, as I said, is what we're looking for now. The caveat being, of course, that these were a slightly milder group of people to start with. We do have to be cautious. Bezafibrate is an old drug. It's a little bit dirty, and it can cause some problems, one of which is a rise in creatinine. So the kidneys can be squeezed a little bit, so we have to watch that. But they did show an interesting potential signal also around itch. So we know that obeticholic acid can make itch worse, but bezafibrate actually, if anything, can improve itch. So that may well make it a very attractive drug for some people, particularly if they've got itch. So it is one of the important differences. The point is we have therapy options. Now, a number of you will know Jess Layton, who's been working with us. She was a student, she's now a junior doctor, and she's coming back to us. She wants to do PBC research with us, and has done some really interesting work about ownership of the problem. This is a theme we keep coming back to. Own the problem, own the solution. And so this is a national study, and she looked at whether people, in essence, discuss their alkaline phosphatase. I've told you that everything we do in PBC is dictated by that one blood test. Was that discussed with you the last time you went to the clinic? We would discuss it with everybody, hopefully, every time they come to the clinic. So the answer is, for 50% of people, it wasn't discussed at all. So it's very difficult for you to understand what you're trying to do with treatment if you're not talking about the key facts. Of the people who did discuss it, about 25% of people in total, the doctor introduced it. That's probably perfect care, because that doctor is likely to be doing it to every patient if they raised it. In 10% of people, the patient raised it. That's fine for them, good for them, but that probably means the doctor isn't raising it, so that's not good for other patients. But what I haven't shown you here is about 90% of people would be confident to raise it, but wanted some guidance about what to be saying. And we're working on giving people guidance. So own the problem, own the solution, and challenge your doctor. Now, so optimum treatment, URSO, check response, and then give second line therapy, and then add, to the second line therapy, etc., if it doesn't go right. However, at the same time, remember that PBC can cause cirrhosis. It doesn't do it commonly, and everything we do is aimed at preventing this, but we need to just know whether that's happening and then to manage people appropriately, because although the complications of cirrhosis are pretty rare in PBC, they are things that can really hurt people, so we watch out for them. And the other important question is when do you refer somebody for transplant? Don't miss the opportunity for transplant if that's going to be necessary. And this is a picture I show whenever I'm teaching about PBC. It's really important because most doctors don't understand this. And that is that the rhythm of PBC is very different to types of other types of liver disease. So in a disease like hepatitis C or NASH, the disease deteriorates quite progressively. So it goes downwards in a predictable way. PBC, however, stays stable for long periods of time, but then it can deteriorate quite rapidly. It's to do with the nature of the disease. The problem is that throughout the disease course, the patient with PBC looks better than the patient with NASH. Their blood tests are better, they're less jaundiced. They look like they're doing well. And of course, what you're trying to do is to spot when people reach that point, because then it becomes quite difficult to get people into a transplant program whilst they're deteriorating. So everything we do in the clinic is to spot people. But people who are new to this or less familiar don't really get this, that actually small changes in bilirubin can worry us because we're always worried about this tipping point. So the rhythm of PBC is different. I always tell people I want to know everybody in the region who's got a raised bilirubin with PBC, because Jess and I want to know what's going on with them. We want to know what they're doing, and we want to know if they deteriorate at all, because we're worried about this point. So PBC is an art, and we need to have people who understand it. And that's probably the biggest trick where there were problems around COVID, is that sensible, intuitive management is what struggled. And then symptoms. So what you put in the guidelines is you absolutely must ask people about symptoms, because they are really important to patients. And that is about asking people and then managing, in particular, itch and fatigue, because they're really important issues for patients. Quality of life impairment. The younger you are, the more the quality of life impairment is. And I'm nearly 30 now, so I know about advancing age. Well, okay, 35, I admit it. But it's interesting, if somebody says to me, I mean, obviously this doesn't apply in COVID, if 20 years ago my missus had said, we can't go out this evening, I'd have gone, oh, that's a real shame. Now if she says we can't go out this evening, I go, yes, it's an early night. So people at different ages in their life miss social activity more. So I think a lot of younger patients, particularly if they're single or just building their life, building their networks, to not be able to do that because of symptoms really hurts their quality of life. And I think perhaps people a little bit later, they perhaps have lower levels of things that they want to do. They maybe miss things less. I don't know. Maybe that's an oversimplification, or it might be severity. The bottom line is there's a double whammy. So the group that are less likely to respond to therapy are also less likely to have a good quality of life. So the two big things that we're looking at, and there are a couple of really exciting developments in this. So the first is new drugs for itch. So this is the trial of LIVErNORTH, who a number of you will have known, who's now down in Leeds. This is a novel drug from GSK to control the itch. I just saw the data an hour ago from the next phase trial, which is strongly positive, and interestingly improves quality of life as well. It improves overall quality of life, reduces symptoms of social isolation. People are benefiting from it as well as getting specific itch benefit. So we've got this new drug coming from GSK to control the itch. And there is, of course, bezafibrate. I mentioned its potential use as a second-line treatment, and I mentioned the fact that there was a hint about itch. Well, there has now just been a new trial done by the Dutch looking at specifically at itch, and in orange are people given bezafibrate, in blue is the placebo group, and 50% or so of the people given bezafibrate had a significant improvement in itch. So we'll increasingly be using the drug in people with itch in general, but also in people who need better control of their PBC with itch. So that's also very exciting. And what I said about second-line therapy, having options is good. And this is the ladder we use for PBC. This is drawn by Jess, who's better at PowerPoint than me. And we wonder if bezafibrate actually fits in here ahead of a drug called rifampicin, which we currently use quite a lot. So we aren't quite sure where it fits in. We are using it increasingly to manage itch. So it's a really important, interesting evolution. One of our problems with itch, though, is the real world data suggests we're actually not very good at it. And again, I would like to think we're better here, but if you go across the whole UK, so this is UK PBC data, what you can see is these are people with persistent itch. This is itch more than 4 days a week. Only 35% of people are taking Questran, only 10% rifampicin, 5% naltrexone. You add them together, about 2/3 of patients only are taking any form of therapy for their itch. So 1/3 of people in the UK with persistent itch with their PBC are not taking any therapy for it. So before we get excited about new drugs, we need to nail down getting basic treatment out to people. And again, COVID has shown the weaknesses in all of this. If people, when they were seeing their patients, weren't giving therapy as they should have done, then they're sure as anything not doing that in a sort of COVID environment. So simple things done well every time is, as I said, my mantra. And then fatigue, you've seen this before, but it bears repeating. I think there is a really important, interesting new direction in all of this. So treat the treatable. This is the complicating factors such as anemia or thyroid disease. Ameliorate the amelioratable. This is controlling depression, autonomic dysfunction, sleep disturbance, and then helping people to cope, and then for us to empathize with people to help them to cope with their problems. So this is a training mantra that we use again and again and again and again, but useful for patients to understand what we're doing. Coping, I can't emphasize enough, and this is a big focus of everything we do now. This is a really important part of learning. Own the problem, own the solution. Pace, energy management, regard energy as a valuable commodity. Use it as you would use money, sparingly. Day planning, fatigue's better in the morning, plan the day accordingly. Owning the problem. Owning and understanding why it's going on. Don't blame me or Jess, or there's no point in blaming people. You need to get on and crack it. We watched a fascinating film at the weekend that was an eye-opener for my kids, which was called The Martian with Matt Damon. And it's about a guy who's an astronaut who's marooned on Mars until he's rescued. And you think it's going to be a kind of sci-fi-ish thing, but it isn't. It's about somebody's resilience in difficult circumstances. He realized he'd been marooned on Mars, that his colleagues had all gone. It was going to take him a year to be rescued. So he knuckled down and said, what am I going to have to do? I need to stay alive. So here are the things I need to do. No point looking back, no point being fed up, no point in blaming people, get on with the solution to it. So a very important point. And then lifestyle, keeping and building social structures, exercise, diet, and antioxidant vitamins are things that people try. Empathize, important. Empathy, not sympathy. Fatigue is real, treated as such. And then the final point is that one, which is simple things done well every time. Where does this go in the future? Well, one of the things that we're very excited about, and I talked about the last time I spoke to LIVErNORTH, is that we are about to start a trial because we think that obeticholic acid may be a really effective therapy to give to people to prevent the onset of fatigue. And so we have a thing called the OAKS trial, which is on hold at the moment with COVID inevitably. But we think that we're probably heading towards novel therapies and approaches to therapy to control fatigue. So we have a handle on all of the problems in PBC. We have solutions to almost none, but we have an approach that allows us to understand where risk lies, understand what we're trying to achieve, understand how we can both prolong life and also make that life better, and do so in a way without making people worse in terms of their treatments and side effects. And my last comment is one of admiration to LIVErNORTH and the other groups, because I think everyone's done just a phenomenal job of supporting during COVID. We are about to enter a golden time for PBC therapy, and the PBC community has benefited enormously from industry interest and from novel trials. And I can tell you now, industrial partners just love working with PBC patients because they are such good participants in research who are interested, engaged, stick with it. And so moving forward, there are going to be some fabulous drugs coming along, which really I think will make a difference. And so if you are minded to take part in a trial, now is going to become a very good time to do it. And one of the things that will come out from COVID is to move away from too burdensome trials, so be able for people to participate in trials at a distance. And I think that's my last slide. So that's me done. That's PBC in 2020. My mantra is always a lot done, a lot still to do, but watch this space on these emerging trials.